Ladies and gentlemen, please welcome to the stage Assistant Secretary for Technology Policy and National Coordinator for Health IT, Tom Keane.
Welcome, everyone. Good morning, and welcome to DC. There's no place better to be in the world than a ballroom in a hotel in DC in February. I hope you're all enjoying the balmy weather. And for those of you from warmer climates, you have my apologies. And for those of you from Chicago or Boston, we're going to be having a barbecue outside after the meeting. Let's see here. I've got the highlight of my speech is going to be a few housekeeping items that we have here. Since I can't see the slides, I'm going to tell you from my notes here what they are. First, we have an app that you can use that I hope you can access without special effort for the duration of the conference. We tested it extensively, which in federal government terms means that 3 people tried it and only 1 got locked out. I'd also like to emphasize that tomorrow we have an early start at 8:45 a.m. My boss, the Deputy Secretary of Health and Human Services, will be speaking, and one of the ways we can signal the support for the importance of the work that we do is to give him a good audience, so he knows that there are many people interested in this. Finally, the Wi-Fi password is capital ASTP 2026, in case you need to multitask during my talk. And yes, it is case sensitive because cybersecurity and because we enjoy watching people futz with their phones while I'm talking. So I'd actually like to start. I got an email yesterday from Medell Briggs Melanson, who many of you know was the head of high tech for several years. And she sent me a wonderful email, and I asked her if I could read it, and she said yes. My recent experience caring for my mother has left me both inspired and profoundly disappointed. My mother has early-stage dementia and which has rapidly progressed over the past several months, particularly as she navigated my grandmother's illness. With a 2-week period in Georgia, I expedited 4 appointments: primary care, gastroenterology, neurology, and neuroradiology. Each clinic operated with a different patient portal, each with separate login requirements. Because interoperability was not universal, I now manage 4 distinct portals for my mother's care. Additionally, my mother was prescribed a new and costly medication for her dementia. For more than a week, I served as the intermediary between the provider, health plan, and pharmacy to secure approval and dispense the medication. The volume of prior authorizations and clinical justifications was overwhelming and notably still communicated largely via fax. This occurred despite my mother having robust financial resources, PPO insurance, and a daughter who is a physician. In the end, we ended up paying for the medication out of pocket due to system inefficiencies. The experience was exhausting and heartbreaking when I consider individuals who are not as financially or geographically privileged and who do not have a family member with the knowledge or capacity to navigate a complex healthcare system on our behalf. I share this experience because it underscores, in very real terms, the urgency and importance of the work ASTP is leading. So for everybody here, this was a great share, and it tells us how important our work is. And I hope that we all keep this in mind during the duration of the conference. My office, the Office of the Assistant Secretary for Technology Policy, is the principal federal entity charged with coordinating nationwide efforts to implement the most advanced health information technology and to assure efficient exchange of electronic health information. My job is to reduce friction so that information shows up where and when it is needed most, for real people in real moments of care. Where and when it matters most sounds like the tagline for a food delivery app. And honestly, we could learn a thing or two from DoorDash about getting things where they need to go quickly and at the push of a button. When your dinner can be tracked down to the driver's shoe size and favorite playlist, it's reasonable to expect that lab results show up too. At ASTP, we are advancing that mission with a strong focus on data liquidity, affordability and access, and technology advancement. The goal is simple. Let's make healthcare more affordable by eliminating barriers in the system that keep data locked up and unusable. Every unnecessary fax or portal login is a friction in our healthcare system that takes time and treasure away from achieving better care. And that's what we're working together to eliminate. Somewhere, a fax machine just turned on because it heard me say interoperability. And I'm hoping that we don't have a future in which an automated robot walks to a fax machine to fax a medical record to be received by another fax machine received by an automated robot. Let's talk about affordability. In July, with our HTFI-4 final rule, we finalized 2 new policies that will reduce costs for consumers and root out efficiencies in healthcare. First, by the end of 2027, certified EHRs must support functions to facilitate electronic prior authorization. This will save providers an estimated $19 billion in labor costs over 10 years that they can redirect back into patient care. Second, by the end of 2027, certified EHRs must show providers patient-specific real-time prescription benefit information at the time of prescribing, including if the medication is on formulary, the patient's cost, and the cost of alternative products that are clinically similar. Instead of the patient hearing at the pharmacy counter, that will be $400, the clinician can see the cost in the visit and choose the $25 alternative that is clinically similar. Real-time pharmacy benefit gives clinicians the power to have cost conversations before the patient hears them at the pharmacy counter, which is a better place to have them than in the parking lot of the pharmacy after the patient suffers from sticker shock. We will see abandonment plummet, adherence skyrocket, and health outcomes improve. Let's talk about data liquidity. ASTP is looking to increase data flow in support of care. Under this administration, we have accelerated our efforts to grow and evolve TEFCA as a critical component of the affordable, patient-centered health system. I am proud to tell you that because of all the work done by my colleagues at ASTP, by the recognized coordinating entity, and many of you in the audience, TEFCA has grown significantly over the last year, and we are delivering on ASTP's statutory mandate to stand up a trusted, nationwide framework for health information exchange. As of today, nearly 500 million records have been exchanged across more than 70,000 participants and sub-participants on TEFCA, up from nearly 10 million at the beginning of Secretary Kennedy's term. This hockey stick graph shows that after the administration signaled support for the data network's use skyrocketed. These numbers speak for themselves. TEFCA is quickly becoming the national network for health information exchange. I am excited to share that the Social Security Administration has joined TEFCA as a participant, selecting eHealth Exchange as their QHIN, and we will be announcing further government involvement in TEFCA in the weeks coming. We are getting closer to a reality where Americans can, across different medical record providers, consolidate their medical records into a single source on their phone without 17 different logins. And these days, 17 different logins sounds like a low estimate. It's probably more like 34 with 3 password resets and a couple of lockouts. The progress is exciting, but the work is not done. TEFCA is built on trust, and as the saying goes, trust is earned and easily lost. My team and I are working with the TEFCA community every day to build and maintain that trust by building transparency in processes and in network governance. Let's talk about folks with a business strategy of information blocking. This fellow I knew this guy's terrible advice would really be worth the money because he was standing in 10-degree weather doing an ironic cosplay in Chicago. So, for more than a quarter century, HIPAA has guaranteed patients the right to access their health information. The Cures Act sought to allow patients to access their electronic health information without special effort. Of course, one of the biggest obstacles to data liquidity is information blocking. Let's be clear, no one, whether it's a doctor, a hospital, or an EHR vendor, should be allowed to hoard health information for their own gain. Since launching our information blocking complaint portal, we have received over 1,500 submissions. Since the Cures Act passed almost a decade ago, not a single enforcement action has been taken. That has now changed. We are in the process of issuing notices of potential nonconformity to developers of certified health IT. These notices request information and explanations related to potential nonconformities under the certification program. Addressing information blocking is a top priority of this administration, and all levels of HHS up to the Secretary are engaged. The DOJ, FTC, and states are also engaged, and as some of you saw, the DOJ and FTC will be participating in our panels tomorrow. The Secretary and HHS leadership team want people to have seamless access to their health data, and we know that information blocking can get in the way of that access. Let's talk about standards and certification. We also have several efforts underway to update two of ASTP's core functions, standards and certification. First, let me talk about our HTI 5 proposed rule. For those keeping track, yes, we are up to HTI 5. It's like software versioning, but with a lot of lawyers involved. And I can tell you, having been in this role, unlike software versioning, where you can click remind me later, you can't do that with lawyers. My lawyer is sitting in the front row and laughing, so she's not going to drag me into a room after this and tell me that I'm in big trouble. The HTI 5 proposed rule removes 34 criteria and modifies 7 of the 60 certification criteria. The proposed rule enables ASTP to reset the certification program's regulatory scope and to establish a new foundation on which to build FHIR-based API requirements in the future. I encourage all of you to carefully review the HTI 5 proposed rule in its entirety and to understand the full suite of proposals. Tell us what you like, what you don't like, and how we can improve the proposed policies. Each comment will help inform our final rule. Comments are due by February 27th. Let's talk about standards. I also wanted to highlight the release of US CDI version 6. No, I'm sorry, version 7. 6, 7. Yeah, that's so the people who sit in the back too far away to see how old I am think I'm young and hip. This version advances the Make America Healthy Again agenda by expanding standardized health data needed to support disease prevention, nutrition, healthy lifestyles, and safer care across settings. I'd also like to highlight, yeah, there you go. Was that enough time to read it all? Comments are due at the end of this speech. We also have 2 recent announcements that I'd like to highlight. First, Secretary Kennedy recently announced the selection of 9 nationwide pilots programs to test health IT standards developed that strengthen behavioral and physical health integration through improved information exchange. The pilots are being funded through the Behavioral Health Information Technology Initiative, a $20 million SAMHSA initiative being implemented in partnership with ASTP. 45 exchange partners across 9 states will test behavioral health specific data elements in real-world behavioral health settings nationwide. Second, I wanted to announce that in the coming days, we will launch the EHI Ignite Challenge, a 2-phase prize competition intended to spur development of new tools to make EHI exports more understandable and actionable for patients and clinicians. And finally, speaking of transformative technology, it would not be a health tech discussion in 2026 if I did not discuss AI. I'm legally required to mention it at least 3 times, or the tech industry will revoke my speaking privileges. I believe that I'm also required to mention that AI will either transform healthcare or will boil it all down into a 3-bullet-point PowerPoint slide. The administration is leading with a try-first culture of AI. The action plan released by the White House in July 2025 discusses how healthcare has been slow to adopt AI due to a variety of factors, including a lack of trust or understanding of the technology, a complex regulatory landscape, and a lack of clear governance and risk mitigation standards. We are taking a light regulatory approach to allow this transformative technology to help us live long and healthy lives. But we want to hear from you. In December, we released an RFI to seek broad public input on how HHS can accelerate the adoption and use of AI as part of clinical care for all Americans. Comments on this RFI are due by February 2023. And while I'm giving you guys all work, I would also like to talk about something that is near and dear to my heart: diagnostic imaging. Radiologists have long said that images tell a story. Unfortunately, that story is less helpful when it arrives 2 days late on a CD and you're sitting at a computer that doesn't have a CD drawer. I'm thinking that the young people who laughed at the 6-7 joke don't even know what a CD is. But it is the way that diagnostic images are transferred these days. Please comment on the diagnostic imaging RFI by February 2023. In conclusion, I want to express my sincere gratitude to all of you here today. You are the ASTP community, and you are leading the real work to make the U.S. healthcare system work better for providers and patients. You've chosen to work in a field where success is measured by things working so seamlessly that nobody notices. Your work is more like being a stagehand in a theater. When you do your job perfectly, the audience never sees you, but the whole show falls apart without you. And I'd like to remind everybody of what Madeleine said in her letter. She has a way out because of her position, her financial position. Most of the country does not. What you do matters. Every connection you enable, every barrier you remove, every portalitis case you cure, every clinician you save from password reset purgatory, it all adds up to a healthcare system that actually works for the people who need it the most. So thank you for being in the trenches, for caring about the details that matter, for caring about people, and for making my job easier by actually doing the work that I get to stand at the podium and talk about. Thank you all. So now I'd like to introduce our next panel. It's the Health Technology for Transparency and Affordability panel. They'll be coming to the stage forthwith.
The lights are a lot brighter than I expected. I asked the team to make sure that my good side was showing, and most of you just get the bald side on this part. So in addition to the podium. Hey, I'm Steve Posnack. I serve as the deputy for Tom among some of our other colleagues here, many of our colleagues here, I should say. One thing I just wanted to note, if we could have 3 quick claps for Cannon. He is our MC, director of the show, the guy that since we're in award season, the camera cuts to at the middle during a camera break to show all the chaos that's happening. And much like interoperability, if all goes right, you don't see Cannon at all. And that's probably the first time he's been compared to interoperability, but just a quick clap for Cannon. Thanks. Complaints go to Cannon. Compliments go to Tom. Just make sure we keep those things established as well. I did take my ethics training, so our feds can't accept gifts, but you can give them high fives. There's a lot of work that was involved in sessions today, so please thank a Fed, especially our team that's led the creation of a lot of, I think, thoughtful sessions relative to the work that we've got going on. And along those lines, we're here to talk about transparency and affordability. Tom did a great job teeing that up. We jockey for what the most exciting session title, would be, as many of you are familiar with, doing events like this. And I was almost thinking of leading a chant with the crowd of, what do we want? Transparency and affordability. When do we want it? Now. We can go outside to the sidewalk later if you'd like during lunch. Want to do quick introductions for everybody, and we'll just go straight down the line. So Cynthia, why don't you kick us off and let us know who you are and what you're up to.
I'm Cynthia Fisher, and I'm founder and chairman of PatientRightsAdvocate.org, and we seek to have full transparency into prices up front, itemized billing, and payment integrity, showing the financial money flows to have integrity to those very prices. Essentially be able to create a functional and competitive market in healthcare, benefiting the consumer to lower costs, have affordability, and have integrity in preventing overcharges, errors, and fraud.
All right, we'll hear about that in a little bit. Jocelyn, please go ahead.
Cynthia might be my new favorite person. Jocelyn Keegan, I work for Aetna. I run our interoperability team, which is part of CVS Health. And I own really the strategy and the execution of how we're trying to simplify and show up for our members and our providers with better tools. And when I look at the work that we're doing, I'm thankful to be here with this group. We're at the tipping point of that becoming possible. I'm a recovering product manager, and prior to joining Aetna about 18 months ago, I ran Da Vinci, which is one of the projects that a lot of the standards development progress that we're making is based upon.
We'll get to that.
So much fun.
Colin, go ahead.
Hey, Colin Banis. I am an internal medicine physician still practicing, currently the chief medical officer for a medication management e-prescribing company called Dr. First. And I am a recovering CMIO. For 17 years, I was at VCU Health as a hospitalist and chief medical information officer during the meaningful use years. And at Dr. First, we're really trying to innovate in the medication management space around transparency and friction.
Sumit.
Hi, everybody. Sumit Nagpal. I'm a serial entrepreneur. Been in what we call digital health for the past 35 years, building my fifth company. With my fifth company, I took a little bit of a detour or a change, approaching the problem from a consumer's perspective rather than a provider or health system perspective. I'm also here representing HIMSS. I'm on the board of HIMSS. I've been on the board for 6 years. And really, thank you for having us.
All right. First question. I feel like it's a game show now at this point. So Tom already covered a lot of our buzzwords. Healthcare loves buzzwords. Transparency, affordability means a lot of different things to a lot of different people, depending on the context. Cynthia, could you give us a sense of what that means to your organization, how it looks, what it looks like in practice?
Well, we know where we want to go. Obviously, and as Sumit said, when you look at the consumer, it's really the consumer who is in great need of having access to the information, to be able to know in advance of care, what are they going to have to pay? What are they going to be responsible for if they're covered by an insurance carrier like Aetna or United or Blues, whomever? What is truth? And then to have integrity in billing. Okay, so that having itemized billing under standard format would be great. And then to have the claims payment that is shared with the employer or with the government based upon how the coverage is paid for. But ultimately, let's remember that the true payor is the patient, is the American worker. The American worker pays for all of healthcare, and the American employer out of wages, out of what is take-home pay, and earnings. And yet that consumer is the most ill-informed or non-informed in the healthcare equation. And yet it's the individual, too, who, if we're going to have the best outcomes of care, we need to have the best information we possibly can. So today I would say that the office, I want to thank for sure, the first Trump administration got hospitals and insurance companies to have to post prices, and Biden kept that in the second. And now we're here in the second administration, and applaud Secretary Kennedy and the president for coming out to say it is time for maximum price transparency and maximizing access into accountability into the fees of all the middle players that are capitalizing on the point of patient care. And we have a long way to go because, frankly, there's been a lot of obfuscation. We're 5 years out now, almost 6, right? And there's been a lot of obfuscation, both in the hospital files and in the insurance files, that I believe have a great opportunity to be well overcome. And in today's age, all of you with all your great skills and technology can pull back that curtain and make it happen. And I'm encouraged with the progress and our best friend Mo, which is momentum, to deliver transparency to the consumer.
Awesome. Jocelyn, you got a big footprint of work that you've got to deal with at Aetna, so give us a sense.
Yeah, and I really love the way that you frame that question, because when we look at it, we understand that there's a lot of technical plumbing, right, underneath, and the enablement, and we'll talk a little bit more about the standards later. That's important. But sitting in the seat that I've been in for the last 18 months, that ability to be able to translate like the so what, the impact of simplifying that message inside of these large complex organizations is really important, but also our ability for the consumer and for the provider that's caring for the consumer. Tom's example was great, right? It really is at the point of care, we really want that transparency. We want information equity for a member, for a provider, for a patient. And so we're making investments in that, simplifying that story and making it human readable. We've made massive investments in Aetna Health, our member-facing application. And again, I chose to go work for Aetna because I feel like we're uniquely positioned with the different assets and with partnerships with my colleagues at CVS to really press on that, not just for our members, but for members in general, to be able to take advantage of the emerging standards, to be able to get to that transparency, to be able to understand what actual cost is. And I think as we go into some of the other questions, the shift really of having to have the information in that immediacy to move from what happens today, which is largely retrospective, to more real-time data. The tools are there for us to do it. We're super excited to execute and be able to get that better, cleaner information. For a subset of our commercial clients, we've rolled out a solution this year called Smart Compare that literally allows a member to be able to understand who's in their provider network, the quality of that provider, and what their price point is. So really allows a consumer to drive their own healthcare journey. In many places, that you're just not able to do that today. You sort of wait to see what comes through, right, in the bill retrospectively. And so that's really important to us. And we think that the better we can do with information up front to a member and to the provider that's caring for them, that will reduce all of that back-end churn that causes so much distress and waste and anxiety in people's lives today.
Yeah, and Colin, thank you, Justin. And Colin, you operate in a very high volume space. Subtle changes can make a big impact. Can you give us a sense of the affordability and transparency side from your perspective?
Yeah, a couple things come to mind, and my colleagues here used a couple of words that really resonated with me. Notice they both said information rather than data. It's important that we're not just giving massive XML markup files that are incomprehensible to the user or to the patient. You really do need the information, and it needs to be contextual, in that real time, as you guys said. And then obfuscation. It's a big word, but it's a good word because I think I'm in a unique position where I'm a patient, I'm a doctor, I worked on EHRs and clinical decision support, and now I work at an e-prescribing medication management company. And I still, when prescribing, often cannot figure out the rules. I can't. If you've heard me on any of my podcasts or things like that, I will say very candidly, we all have better visibility into the Domino's pizza order than we do to a life-saving medication in terms of status, where it is, what it's going to cost, when it's going to arrive, et cetera, et cetera. And there is no reason that this cannot be conquered in the year 2026. The the fact that we're still talking about interoperability, you know, back from 2011 meaningful use days, now we've come a long way. I just don't think we go fast enough. And I'm glad to see that I think a lot of the pressure now is coming from the patient side, actually. It's, why can't I have the similar experience that I can in aviation, banking, retail, in healthcare? And so let's keep the let's keep the pressure up, because I actually think we're starting to accelerate, and I'm excited.
Great, great. And Sumit, you've been making investments, you've been starting companies. We were talking earlier, where do you see some of the future work in affordability and transparency?
Yeah, I think everyone's touched on so many of the important points that I was going to make, that I'll focus on exactly to your point, where this is all headed. We've been talking about these topics for 30 plus years. And in some ways, we made huge progress. In other ways, we're still talking about the same stuff. There's an overlay that's occurring in our economy, and this is not just in the US, it's happening in other parts of the world as well, where there's an entire parallel model emerging outside what we at HIMSS think of as the medical model. The medical model is the episodic, care-based delivery systems that we've all been talking about, that own the information, or at least maintain it, and that consumers sometimes get access to and sometimes not, and that we all struggle with. Around that, at an accelerating pace, is this health model that's emerging, where it started off with concierge services, expensive, folks who could afford it. But then, as those models were refined, as those models were tested, we're starting to see more and more of those emerge for the rest of us. Right? HIMSS believes that this health model that is emerging around how and where we receive care is actually going to have a profound impact on the fluidity of information flow. Right? Consumers are now, exactly as everyone here has said, demanding access to their own stuff the way that we have access to information about our pizza order. And there are companies that are delivering that. And those companies in a free market setting will, in fact, start becoming more valuable and more used. And we think that the markets will also start playing a bigger role in where this goes. Right? So our position really is, our thinking is that the health model can emerge and sort of dominate, or the health model can join up with the medical model, but the health model is happening, and that's where the future is.
Great, thanks. All right, everyone's got a good sense of what's going on. I let the panel drive itself most of the time and just kind of give them a helpful nudge. So Jocelyn, I'm gonna go to you first real quick. As Jocelyn disclosed, she was on the, I would say, recipe side of the house, and now you're on the cooking side of the house. So where do you see the most impactful points of change and intervention now? You could focus on Da Vinci, a little bit broader. Right. When it comes to affordability and transparency, how are those things getting implemented in the real world?
Yeah, I would say maybe just simply, right? There is the what you have to do, right? And I think many of us work with folks in the industry that have a compliance mindset. And part of the reason that I made a decision to shift seats, and I like to refer to it as theoretical math to applied math, is to actually make sure that this stuff gets implemented correctly. Because I consulted for a lot of payers and vendors and provider organizations in my previous life. I think that the promise of where we're trying to get, to Sumit's point, we've been talking about this for a long time, we're so close. And that what I really see is a willingness to understand not just like the moral imperative, right, of making sure consumers really can drive their own care and that they have the tools to do that, but is that it's smart business. There's ROI associated with taking all of this waste out, and the tools are there to be able to use it. But change is hard, right? And there's a lot of sort of entrenched players that aren't moving as fast as we need them to move. Sumit, I love your comments, right? Like the market is going to evolve one way or the other, and so from my seat and what I get to do on a day-to-day basis, we're really seeing the ability to use technology as a differentiator in how we deliver, how we simplify for our providers, our members, our own internal teams, and really that power of leveraging technology for its highest, best purposes, and not because we have to, but because there's ROI for us, there's value in our NPS score with our providers for it, there's abrasion and better outcomes for our members when they have more access to their information. And these are the things that we should all be running our businesses on a daily basis. And Colin's right, like we are all the consumers here, right? We all have stories about, this is so broken, how is it still broken when we're in the midst of caring for a family member in a really difficult time. And so to me, the tools are there. And the way I look at it, and part of the reason that I made my shift was, to me, it's about execution now, and it's about bringing it to life and driving the storytelling so that we can get to the transparency that we need to have, and the information is in the workflow of choice of the provider or the member. We're not dictating or pushing people to portals to be able to do that, and we're doing that. We're deploying better tools so that people actually can control their healthcare journeys.
And so, Colin, for the real-time prescription benefit related work, you've been involved in that. You've seen it firsthand. How's the experience changed over time for providers, and a little bit of what we can look forward to in that space?
Yeah, I mean, even though I look young, I've been doing this for quite a long time. The fact that we can actually see RTPB transactions within workflow the majority of the time is actually a huge difference. I remember when that was like a pipe dream. And so that's why I sound cynical and say we're not going fast enough, and then you sort of look back and you're like, wow, we actually made a lot of progress in 15 plus years. But there's still, the word trust comes to mind. There's still instances where the providers will not trust the data or the information that's coming back to them, whether it's because that particular RTPB feed doesn't have all of the payers, or it doesn't have a payer, therefore it makes an estimate, and the estimate is way off, and the doctor's been burned by that before, so now they're not even going to look at it. And so there's definitely opportunities to continue to improve and iterate on that simple transaction. There's also, this comes to mind a lot for me, is healthcare is increasingly, actually to me it always has been like a team sport. Nurses, social workers, pharmacists, et cetera. But we still block some of those users, some of those EHR users from actually accessing that information. A lot of the times you can only see an RTPB transaction if you have e-prescribing privileges, or at least the ability to tee it up on behalf of a provider. Well, social worker needs to see what things cost, case manager needs to see those things. And so I think there's little things that we could do in that, just like that could improve it. And I also think improving the trust, improving the data accuracy and the coverage, if you will continue to make a big difference. And then ultimately coupling that with a patient engagement solution that provides the patient the exact same view. I mean, there's no reason that only I, the provider, should be able to see this. The patient equally should be able to see it and make decisions on their behalf as well.
And
the power of APIs. Right?
There you go. Yeah. Maybe we'll get to the tech saving us question in a sec. Cynthia, you see this firsthand with patients every day. The stories that you have help sell policy and advocacy and all that other, kind of helps the narrative. Could you share, from your perspective, some of the maybe most poignant examples that you've got?
Yes, Steve, transparency is truly transformative. And the lights are bright, but I do have to ask, how many of you in your family have experienced an overcharge by our healthcare system?
It's a good amount of hands.
That's a good amount of hands, right? And so this session is about affordability. What we're seeing is price transparency and transparency into billing and payment. What that does is pulling back the curtain, shining that sunlight, and shifts power to the patients. It shifts power to the employers to design better plans to be able to lower the cost of healthcare. And it also, for the first time, gives us prices so that we know whether or not those bills were accurate or not. So look how many of us raised our hands about this situation. And so let me give you a couple of examples at the macro level. Is because of price transparency that you all have done at HHS and Department of Labor and the Treasury to start to pull back the curtain on hospital prices and the insurance prices, even though it's a mess and you have to hire tech firms at a good dollar as another middle player to kind of evaluate it, which we should really be using ChatGPT for comparative prices at this stage. AI should be benefiting the consumer. But that being said, we're learning from lawsuits. So let's go on the macro level what this means on a 20,000 employer plan, self-insured, using an insurance carrier as an intermediary. So that means the employer is taking on the financial risk along with their workers and their families with high deductibles, right? That means the patients and their families are having to dish out. So those prices and accuracy is really important. The employer plan has to sue to get access to the claims data. Why? Why is claims data, why is every receipt not being able to reconcile that checkbook to the actual price? Well, it's because the insurance industry has confiscated that you pay into a trust account and they own the checkbook. And they're hiding that and not allowing audit provisions for integrity in billing. So the employers have come to say, I'm a fiduciary of my spend and we need to get access to the claims, and they've had to sue. So what we found is utilizing the transparency and coverage data, the employer was able to see when they finally sued and years into it got access to the data, they spend $180 million on their annual spend for healthcare for their workers. 30 million of that was overcharged way beyond what the insurance carrier said was the price for those services. Those 30 million out of 180 million were all overcharged. That's 17%. That's huge money when you correlate that across. And that's why we see like Kraft Heinz suing for $1.2 billion, at Aramark suing for $1.6 billion, Ford Motors suing for $1 billion. But come down to the everyday worker, this is hugely impactful, not only from the employer side, but then down to the worker side. So we saw another lawsuit with Johnson & Johnson being sued by the employees for lack of fiduciary duty, and Colin, this was on prescribing. And one of the pieces in the lawsuit said that the MS drug, the employees sued because the every 90-day copay of that drug was $1,725 to the worker to have to pay for that generic MS drug. And the total amount J&J paid and share with that was over $10,000. Now, why is that so expensive? Well, the insurance carrier owned the PBM, the pharmacy benefit manager. The broker was affiliated with them. They get a fee for a conversion to a 90-day fill, maybe a $10 fee to them, plus a fee for the prescribe. And then you've got offshore biosimilars and labelers and all these other entities in between. When the employees were able to look at Walmart or Mark Cuban's Cost Plus Drugs, that same generic drug at Mark Cuban Cost Plus Drugs, cash money, was $28.40 for a 90-day fill. So if we're being fiduciaries to manage money, we need to see all of these prices. And so net, what we've found is at the individual level and across at the macro level with the employers, and look, this is happening in the governments too. The state of New Jersey just filed $100 million worth of fraud that was admitted to by Horizon Blue Cross. Why? Because the hospital for this big cancer care billed $600,000, and $2.5 million was taken out of the state of New Jersey's trust account. Where did all that money go? If we don't have transparency, we can't see it. And the state of New Jersey was locked in to only see 500 claims. Well, they spend almost $6 billion a year. So the only way we can have trust and we can restore trust in this country is to shine the sunlight on all of this and see the wide price variation. And what the hospital price transparency files have shown us is that there's 10 times price variation sometimes in the same hospital for the same care. So for instance, just coming here last night, I got an email. We at Patient Rights Advocate take on anybody who comes to us with a bill that they think is far egregious to what they should have paid, and then we get the data. We have never lost. Every bill has been an overcharge. Every single bill, either by the hospital themselves at the level of coding or the insurance carrier. So what I would say is what we see right now is the opportunity, because at the individual patient level, we just had a hernia repair at George Washington come into us at a $97,000 claim. No complications, didn't even stay for the day. Okay, it was the appendectomy. The appendectomy was done same day, sent home, $97,000. On my way here, I said, what is the lowest price in that hospital file for an appendectomy, clean, no complications? $1,300. Okay? And this was negotiated down to $14,000, and the patient's $4,000 out of pocket. Okay? So stick with me on this. We're trying to.
We're with you.
Okay? But why is that? Why is that charge master? Why did that come out at $97,000? Because I encourage all of you to go to all of your employers and ask if you can read their contract with the insurance carrier. When you see the contract, it will have gag orders in it to not share prices. I'm sorry about this, but it's true.
We didn't intentionally sit the two of you next to each other.
No, I love this because I don't think we
Okay,
will talk
so
about
it'll have gag orders to not reveal prices, which we know is against the law and No Surprises Act. And then the second thing it'll have is it'll say we get to keep 30%, 28%, but let's round up to 30, 28% of the delta of the share of the savings we got you, Mr. or Mrs. Employer, from that funny number. So if you all read your employer's contracts with the carriers, you're going to understand why healthcare, because the higher the prices and the higher that delta, the more money everyone makes in the system. And I'm going to tell you, we're at a point where the war games are enough. It's war games using AI with the insurance industry and the hospital industry and sometimes there's 24 middle players and intermediaries in between, right? And everybody's capitalizing on that patient encounter to make as much money in your revenue cycle optimization as you can. And I'm going to tell you, we are at a crisis tipping point. We are in an absolute tipping point because people are so fearful that they don't get the care they need. They do not get the care they need when they need it for fear of absolute financial ruin, because how many of us raised our hands? And when young people, this is also last night, okay? So I'm like, wow, this is huge. Addiction therapy, a woman came to me who the psych hospital makes her prepay $60,000, but she's totally covered by her insurance carrier in their clause. So she knows she's gonna get reimbursed, but she only got reimbursed $19,000. So they had to deplete their retirement funds, she and her husband, and get a second mortgage on their house to pay for their son's addiction care. Now, he is 29 years old. He's an adult. He was on a separate plan. Why are they fiscally responsible? And it turns out when we looked into the billing, both a hospital and they violated on the coding, and she was just reimbursed in full yesterday by the insurance carrier. So we wouldn't need to be involved to do this. We do this complimentary. I beg any of you, please do send it. We'll keep fighting. But we don't need to be this way. We are at a tipping point where those war games are only crushing the patient and their families. And we're at a point where every one of us has the opportunity to pull to our moral compass, and you guys are brilliant. All of you are the most brilliant. And we can cut out the intermediaries. Because, look, I just tore my meniscus in Washington Ice a couple weeks ago in a couple places, and I ended up in the ER. Last place I want to be ER. My copay was $2,000 estimate for 20% with my employer. Well, we own the company, so that's $8,000 to the company, $2,000 to me, saying that my card made me charge more. I looked at the billing officer and I said, This is just to be in the room, right? I haven't gotten any care yet. This is just to be in the room, $10,000. What's the cash price? $719.65 for payment in full. I took the cash price. But the reality is how many people know to ask?
Right.
So where is the value in that? Where is the value in the coverage? If my husband's going to owe me it's his company, so it's going to really owe me a nice Valentine's Day dinner with my savings. But the reality is where is the value? We've lost our way. Where is the value? Because that's no negotiating leverage. And look, physicians complain that they don't get paid for 3 and 8 months afterwards. They could be paid right away if we clean out all the middle players and everybody runs on it as a cost center and knows what margin is fair. So go to that cost plus model and get rid of all the unnecessary intermediaries as fast as we can, and we can be the most competitive country and allow our companies to be competitive and allow our future and our children and our grandchildren to have a future, healthier, longer lives at a far lower cost.
Thanks. I'm gonna let Jocelyn and Colin buffer a little bit.
Yeah, and I think I'm here for a reason, right? I made the switch to be inside of a health plan for a reason, and I chose to be at Aetna because I've had experience in working with a lot of different organizations. And I use the word moral imperative, I think it's important. Like, the work that we do is so incredibly important, and there is inefficiency and waste. And so one of the things that we've been doing from a team perspective, my small but mighty interoperability team within Aetna is really changing the way that we're showing up to talk to providers in those conversations, is really making sure that we're taking that technology-first approach and the way we're doing things. I sit inside of a provider experience team inside of Aetna. The person that recruited me knew she needed somebody from the outside to come in and sort of open up that world a little bit more. But alongside that, she owns the teams that are also dealing with some of those challenges that you're talking about. Provider data in itself, I'm sure, has a sweet spot and a moment of affection for everyone in the room. But the idea that the tools are here, listening to you and Colin speak, I have a real-time benefit check API that we put out last year, and Ryan Howells and I were talking about it yesterday. Nobody's come knocking on my door to use it. It's live, it's available, the information's there. I actually own the MRF team, the machine readable file team, under my purview. I own all of the compliance projects for Aetna around interoperability. And I'm the person who signs the attestation that we don't have gag clauses in our network contracts. And I'm disappointed to hear that you're still up against that, but that could be legacy, things going through the legal system. But, there's active NPRMs out about MRF, so I'm not going to say anything publicly about maybe some of the limitations of the current structure of that data. But I think that if we're really going to solve the problem, we need to get to the real-time information in workflow so people really understand what their cost is. I do think, this momentum and the way we're changing the way we talk to providers about how to use the tools to get to better transparency, it's not going to fix the mismatch, right? I like the way that I'm not going to use the phrasing that you used, but I think that we're walking into conversations with providers today to say about how can we, and my GA person's going to yell at me, I use the phrase internally, take the sock out of the process for folks, right? Because there are things that there's an insanity about how things have gotten to be where they are, and what can we do with technology, right? Understanding that we are in the business of simplifying, right, and getting care to people, improving their outcomes. But how can we leverage technology like every other industry has to create that opportunity to innovate and to do things differently? And I really believe that the people that are the most successful picking up the tools that are available, because they're there, and find the partners to do that work, are the folks that are going to help transform to that next experience that we have within healthcare. And you have to have a willingness, right? I'm surrounded by people in industry and inside my organization that really understand that we have to be that change, that the status quo isn't acceptable, and that it is about our members and our patients really being able to get the care they need when they want to be able to get it, and that they can do it in a fully informed way that isn't going to bankrupt them or end up with a surprise bill. So
I got something for you. How about, I mean, we know through the No Surprises Act 5 years ago, we were supposed to have the advanced EOB, which is prices first healthcare, before January 1st, 2022. We're looking forward to this administration that's committed to getting that out there. But you don't need government to do that. No, you could do that now. You could give the prices first, advanced EOB, which is then also automatically a pre-authorization. Here's the pre-auth. This is what your share is going to be of pay, and this is this. This is what you're going to pay. And then you could have an itemized bill, and you could also release the payment that's shared with the employer to have integrity to that advanced EOB, and just do it.
Can I get a show of hands? Is there anybody in here that uses their Aetna Health app? Because we do all of that today. That we've made massive investments over the last 4 or 5 years for that transparency.
Estimate or actual?
We give an estimate today, but my
I want actual.
But my team is actually, yeah. But the reality is because it's not regulated, and there is lots of politics around the landscape. Period.
Yeah, but you could have first mover advantage.
So my team is actively testing the patient cost transparency API. That's a FHIR standard. That's the equivalent of real-time benefit check paired with the coverage requirements discovery. I'm going to nerd out here for a minute to essentially get the equivalent of a real-time benefit tool for a consumer. We are driving that conversation in industry, literally with 3 other players, and no one else is coming to play because it's not being regulated, because a rule hasn't dropped. And so you're right, we have to be bold. One of my team members is presenting on PCT is the name of the IG, if people aren't paying attention, patient cost transparency, at HIMSS with the Da Vinci team, because we're actively testing with our vendor and with other players in the market so that should be a reality.
All right. I'm going to pitch the rights to the Cynthia and Jocelyn podcast later.
I mean,
Stay tuned.
We have to fix it.
Stay tuned.
We have to fix it.
You know, Sumit, part of as we were listening to this conversation is like, you know, where do we go from here? The cost sensitivities that are involved, the affordability issues that patients face. What are you seeing from your perspective?
Well, look, firstly, your words and your passion, that's probably the best vision statement for why, you know, so many of us wake up every morning and get to work, because these are the problems to be solved. And having said that, just even the letter that we heard in the keynote, you know, not probably very few people in the audience don't have some experience like that to talk about, or many. And it's been years. It's been decades. And so, yes, we're making progress. Yes, we're starting or already sharing stuff. And yes, we're implementing technologies that comply with what we're supposed to be doing. And yet, we all recognize that if this were any other industry with a free market where consumers were the ultimate buyers and they could go buy from whoever they wanted, that this industry would not exist as it does. And your point about, you know, cost plus was just a really great example of what we're talking about when we say health model. So the word insanity was used a few times, right? And ultimately, you know, I've been told this in my career as well, that, you know, the definition of insanity is to do the same thing over and over again and expect a different outcome. Well, we've been doing that in this industry, and we're still doing that. And I don't think that that's how we're going to go solve, ultimately, the friction, because no matter what we do, it's still working for the parties that we're trying to solve it with. The friction still works for them. And so really, the solution to this is not going to come from inside. It's going to come from competition. It's going to come from new players. And it's going to come from consumers actually being able to make those choices because those new players have emerged. I just don't see how 30 years in, there's going to be a different outcome unless there's a fundamental change like that.
Yeah. And so, Colin, help connect the dots, or maybe across the kind of medication transaction flow, for the real-time prescription benefit, prior authorization as it fits in, and what the clinical workflow looks like relative to the patient dynamic. I mean, Tom gave a great example during the keynote. I raised my hand earlier, said it's like I show up at the pharmacy, and we had a discussion about what I was supposed to get, and then I go there, and I have great insurance from the federal government, and it was still like several hundreds of dollars, and I was like, nope. So how do we get the education and literacy part into that conversation?
Yeah, it's funny because when that happens and you don't pick that medication up, like I don't find out until the next visit 6 months later, and now I've lost 6 months, a year of cholesterol, whatever. The best decision support is, I would say, the right at the right moment and not necessarily intrusive. Different providers want their decision support in different ways. Just like we all prefer to get our communications different ways. Some of us like text, some of us like email, some of us look at Twitter or X, whatever we want to call it. So we need to be very thoughtful on how we implement these interventions. I would say the best prior authorization is one that I never have to do. And we can be smart enough to nudge the provider to provide extra context in the middle of that prescription conversation and transaction to say, you know what, if you just add a diagnosis code here, chances are you're gonna skip the PA or you're gonna jumpstart it and save a couple weeks. But the doctors, sometimes we feel like we're playing a game that we don't know the rules to. And the rules vary across payers and patients, et cetera, et cetera. And so I do have great hope for AI to help in this capacity. I've been doing informatics for 20 plus years. I've never seen anything adopted at this rate. I've never seen providers actually ask for something technology related. The EHR was kicking and screaming, and now ambient scribing and all of these other things are table stakes. It's not even like novel anymore. And so in order to empower the patient and the provider, we're going to just keep coming back to that transparency. You need to be transparent, and it needs to be in the right moment, in the right workflow. Because what we're doing now is kind of, it's still antiquated. We've had e-prescribing for 20 years. Like, you can read my handwriting now good. I get some drug-drug interactions and maybe some other benefits along the way, but it's still a very, fire and forget, ping pong because you need to change this. Oh, I need to get the pharmacist. Come on, 25 years later, we could do better. And that's what I take pride in working on with Dr. First. And so transparency within workflow, all of those things that we've been hammering home for so long. But I do think we're at this inflection point for technology. I think we're ready to embrace it.
You gonna add something?
Yeah, as I was listening to this conversation, I was reminded of a moment. Part of my career, I've spent a lot of time in the UK working with the NHS there as well. And maybe 20 years ago, about that time frame, I was in a meeting, in a presentation in Leeds, where I had just given a vision for data interoperability and how information across that entire city region could be pulled together. And then somebody else got up and started describing how they were going to, over the next 10 years, follow a path to cause that to happen. And it was all about some of the same standards that had to be developed, and they talked about all the same stuff that we've all then lived through over the past, that same period. And I remember this moment where somebody in the audience, who over time became a really great friend, got up, he worked for the NHS, and he said, "That's just a really great vision. Who is going to care for my parents now?" Right? And I think that's what it boils down to. What you're hearing from me here is, yes, these are all important steps along the way, but that word, the momentum, and actually the speed, that's what we're all missing. And that was the point that gentleman made, and I think today we're still looking for that speed. What about us today? When are we going to go solve this, right? And we don't think that the medical model alone can do that anymore. And we also believe that because of the changes that are happening, because of both entrepreneurs coming in and because of changes in regulations that are emerging, that are opening opportunities, that these experiments are now not just being tried, but they're now starting to scale. And so the health model is key to addressing many of the topics we're talking about here.
Yeah.
It'll build on the same stuff, but it'll operate at a different pace.
Yeah. Jocelyn?
Yeah, this is where my inner recovering product manager comes in. What Samit is describing, right, is the impatience, right? We all need to be impatient. But this idea of incrementalism, right? And I think often we expect technology to solve all of the problems, and we never account for, and I'll use an example of prior authorization, the knowledge that is in that workers, that nurse that's doing PAs all day long in a back office for pharmacy 10 years ago, all of the nuance and understanding that that person had and the little side workflows, you have to grow into that to get to a fully digital experience. And I think on the pharmacy prior auth side, we're there. I helped bring the pharmacy prior auth standard live a decade ago with our friends at Cover My Meds when I was at Navinet. And day one, getting people to use it, there wasn't enough full functionality, right? And so if we think about this progression and technology being an enabler, I'll use a more recent Aetna example. We've struggled to digitize our facilities that aren't hospitals, right? We think about our SNFs and long-term care. I did some work in that before I joined Aetna, and we have a digital desert there. And so we're doing things like creating better connections, getting more connectivity with those facilities, right? But the reality is people are still showing up in an ambulance with their records pinned to them, right? When they're in a transition of care. We have financial incentives and provider or member experience incentives to improve those processes. So while we're alongside trying to improve the digital footprint, my Med Affairs team and my clinicians inside of Aetna are physically putting nurses into hospital settings to provide that bridge, that human connectedness, to be able to, we sort of do this, everything that's old is new again, right? We're using the human to bridge where the technology isn't there yet. And it has to be, technology has to be an enabler. It's not the answer. And I think that doing this work to really understand what those bigger pain points are the thing that's going to get us to the today solution, even if it is a more human intensive, not permanent, but it's gonna allow us to get to that incremental path. Because the reality is the plumbing and the bits and the pieces is really complicated, but we can abstract for all of the users of the system from that if we're really smart and thoughtful about what that entire experience is like, and not just thinking we're gonna deploy tech and that's gonna fix the problem for us.
So we're getting close to time. Covered a lot. I think some of the warts and all of the healthcare experiences today. We'll transition a little bit to more perhaps the optimism that we've got there. The team knows I like to go on metaphorical journeys. So like the one I have here that I was thinking about this morning is you have the movie scene or a show, favorite character, they get knocked off or fall off some type of thing, and you just get the director's cut of a hand and a backdrop. And then the crescendo of music, and someone grabs them. And is that the technology moment that we're at right now? Is the automation there? Is the AI there? Should we be as optimistic as we are? Is the hype real, in terms of the hand grabbing back and catching us?
Did you watch Stranger Things?
That was one of my recent examples. I didn't want to we have pop culture quizzes for some of the staff around town. What do you think, Cynthia?
Well, right now AI and those hands are behind the curtain of obfuscation. And again, it's war games between the insurance carriers and all their intermediaries capitalizing on the patient's misfortune, as well as the hospital, to charge as much as they possibly can and profit as much as they possibly can. When we win is when that's all pulled back and it's done transparently. And so in front of the consumer, in front of seeing all the prices, itemized bills, and payment integrity. And then we can restore trust in our healthcare system. And so, look, this happened in property and casualty in the early 80s. I remember because I was an IBMer then, and I was in those meetings, where it goes to standards. And thank you, Steve, for what your organization does. is we could have one standard contract for all providers between the insurance carriers and the hospitals that they use, and then transparently post what are those negotiated rates, what are the outliers, what are the stop loss, what is the entire formula for coding that is standard, and then compare that and let the tech world then develop wonderful tools. So come up with a standard. The other thing is on claims payment and in billing coding. One standards, agree upon standards, not have Aetna have its own or Cigna have its own or United, and then be complete. Show that 835 data, the 837 data, show the entire, what amount was billed, what was paid to provider, when was it paid to the provider, and who got what on the intermediaries. And then let us as CEOs and CFOs, as employers and unions, be able to say, no, I'm not going to give the broker $10 for every prescription that gets converted to a 90-day fill. What value do they add to the equation? When Mark Cuban can do cost plus 15% plus shipping at $28.40 versus over $10,300 for the same MS drug, we have the opportunity to do the right thing by the consumer. And yes, it will disintermediate. It will disintermediate all the unnecessary players. But therein lies the opportunity for incredible innovation, incredible great improvements in health and outcomes, and to be able to unleash not only competition in price, but quality. And outcomes are really, really important. And I'm going to say that every single one of you went into healthcare. I did as well. We all went into healthcare to live the ideal to do better for our fellow citizens. And we can all do better. So I would just encourage the inner compass, the moral compass, as you say, but we know we can go faster. We know we can do so much better. And I respect that, God willing, we'll all live longer lives, but 30 years from now, I don't want to be on this stage still talking about interoperability. So the reality is we can do better now, and you know this industry needs huge disruption. Why? And again, go home and ask for your employer to show you that contract. Why should a preferred provider that is revealed in the contract that the insurance carrier may own that preferred provider be able to charge more and the insurance carrier participate in those profits, and also put clauses in that say, and their billing may not be audited or overseen. And if the carrier as a third party made a mistake and paid that OB $100,000 or the hospital versus $10,000 for that childbirth, they get to keep 50% of the recovery of their own mistake. Okay, is that profits over patients? That means there's an incentive right now in those contracts to make mistakes and overpay. And then finally, I also say drug pricing. Why in the transparency and coverage files do we have drugs that are standardly given in milligrams converted to milliliters that actually could add extra zeros in the pricing? And so we would be killing patients if we were we're not doing the actual standard format of units. I mean, you've probably seen this too, Colin. Let's do standards. Let's put it all out there transparently and let the games begin on providing the best health care at the best possible price, and get rid of all the administrators. They'll get other jobs. My mother was a travel agent. She played, she went and became a really good golfer. Really, we don't need travel agents. We don't need all these administrators.
And scene. Okay.
Exactly.
We're at time. We could have done this all morning. When you create a panel and you bring up a bunch of folks that haven't normally interacted with each other, you always focus on chemistry. And so please give everybody a round of applause for keeping us entertained. Thank you so much. All right. We're all good? Thank you so much.
Thank you. Thank you, Jocelyn. We're happy to work with you guys.
We had a break. Yes.
On exchange plans on Monday, they put out quite a few interesting proposals. One was on catastrophic coverage and how a catastrophic plan up to 10 years could exist. They also put out a rule on a non-network qualified health plan. That's pretty fascinating, and so I'm sure that my colleagues at CMS will be interested in your comments there. Secondly, I think we're seeing providers move to direct primary care models, and you're seeing this change, and what does the primary care landscape look like? And then the question there is, how does that then impact finance, essentially access to care, et cetera, over the next decade? Beyond that, we're seeing costs. So wage growth is largely going into healthcare premium, and so wages may not be growing as quickly as we would expect. And so all that ties into this question of how are people themselves managing their health? And so we have about a third of people using wearables. About 80% of those patients are happy to share that data back with their provider. The question of how that data gets shared back, what providers do with it, is a core question. And I think the elephant in the room is AI. And so how can AI merge? I think it was talked about in the last panel. How can AI take your health data from your EHR, your wearable data, and other device data, and how can it sit on top of that to help your provider and you really maximize your health and your care? So you may be looking at me and thinking, this guy really is the personification of Maha. Like, what can he know about being a policy wonk? And you would be right, which is why I have these 4 people next to me who are much smarter on all these topics than I am. So I'll do some quick intros, and then we'll go on to really the meat of the topic. So first is Dean Sarah Zanton, who's the Dean of the Johns Hopkins Nursing School. She's really thought about novel care models for her career. Capable is one, thinking about frailty, how to help people with ADLs, really live to the maximum of their abilities. Neighborhood nursing is another of her models. And so we'll hear really from the provider perspective from Sarah. Kyle Zebley is the CEO of the American Telemedicine Association. He brings really a policy perspective plus the technology perspective. He's been on the Hill, he's been at HHS, and now at ATA, so grateful for him. Ben Wiegand is really bringing the investor perspective. So he's at Flagship Pioneering, leading their digital health innovation work. Was previously at Johnson & Johnson for 25 plus years, leading the World Without Disease Lab and other work at Johnson & Johnson to think about really how do you change the idea of a crazy concept of a world without disease. And then you really can't have a panel about technology without an actuary. Really, any party that doesn't have an actuary, it really can't be called a party. And so we brought Mark Peterson, who is the chief actuary at NextBen, which is an ICRA company. It's the last time I'm going to use acronyms today. So they're an ICRA company. He's been a chief actuary across multiple plans. He's been at UHG, Optum Labs, thinking about really how do you pay for all of this. So that's what I have. So hopefully you guys can carry the rest of the panel. I did take bets in the break of which of you are going to fight. My money's on the actuary. So please don't let me down, Mark. So broadly, how should we think about, if you had a magic wand, how should care be given in this new world of technology? And then thinking about, your perspective from being the professor of social justice and health equity at Hopkins as well. I think thinking about that perspective would be great, Sarah, as a starting point.
Great, thank you. Thank you so much for coming out today, and thank you for the invitation. Thank you to the other panelists. So as Mark mentioned, I'm the Dean of the Johns Hopkins School of Nursing. We are the #1 school of nursing in the country, and other nursing schools look to us. So besides educating nurses and nurse practitioners and nurse scientists, we also do the research and the science around how could we evolve care. And we can do that without having, universities have this ability to think in a visionary way and be able to pull all the stakeholders together without needing to make a profit or have a particular perspective. And when I'm a nurse practitioner, and I used to do house calls before I got my PhD. And I would go to someone's house who was homebound, and often they had to drop their keys from the 2nd floor into the grass for me to get on my hands and knees and try to find. Or someone would open the door, and I would look to see them, and they would be on their hands and knees because they actually needed a wheelchair and they didn't have one. And yet I came in as a clinician thinking their hemoglobin A1C, their blood pressure, what are they eating? But it was just wrong, because what they cared about was, could they open their door? Could they get downstairs? Could they get meals? Yes, they cared about their diabetes over time, but in that day, they cared about being able to get dressed, being able to prepare some food. So we developed this program called Capable that Mark mentioned once I'd got my PhD and was trained in research methods, which combines a nurse, an occupational therapist, and a handy worker. It's 4 months, and it saves 7 times what it costs. And the reason for that is that people who have difficulties with bathing or dressing or walking across a small room are much more likely to be expensive soon within the fiscal year. And we were able to decrease hospitalizations and nursing home admissions. The reason I mention that is not to do an ad for Capable, but to talk about the ways in which clinicians and documentation and healthcare systems can ignore the daily reality of people's lives. If all we do in this revolution is pull together on a dashboard people's A1C and their blood pressure and how many steps they took, we are going to be missing the boat. Because people's daily lives, their frailty, do they have enough to eat? Can they figure out how to get groceries delivered to them if they can't get out? All of those things, and of course the human in the loop to figure out what, to interpret and help figure out what the indicators mean. And so, and Mark mentioned neighborhood nursing. So you asked a magic wand question. So to me, part of the way we're going to get to affordability is to do a lot more about prevention. And we've said that for 30 years, right? For 30 years, we've been saying we pay the most of any health system in the world, and we have the worst health outcomes. And that's because we pay for tertiary care, and we pay after someone's fallen, and we pay after someone breaks their hip. But in my magic wand world, we would be able to have a sub-layer underneath primary care that has a nurse and a community health worker in every neighborhood, and this is what we call neighborhood nursing. Other countries do this. Then you have all those people connected in each block. If everyone in this front row had the same nurse and you lived near each other, you would also be connected by the fact that you have that nurse. And that nurse would have a dashboard and would be receiving your wearables and any questions that you have and helping interpret for you. The community health worker would be working on some of those social needs, like, do you need access to a food pantry? Your wheelchair broke and you can't get out of the house, but they can help you, interact with the doctor to be able to get the new prescription for your wheelchair. Those kinds of things that if we're just sitting almost like in an airline control room looking at people's blood pressure and their blood glucose, we're not really going to be solving the problems of health, which I know is why we all went into this work, is for people to actually be healthy rather than just drive down costs. So I'll stop there and happy to engage further.
Kyle, please.
Yeah. Well, really appreciate it. Again, CEO of the American Telemedicine Association, also Executive Director, ATA Action. Want to give great thanks to HHS and ASTP for hosting this. They've been amazing partners and have really carried on a lot of work that started in the first Trump administration and was carried forward on a bipartisan basis in the Biden administration. And what's so exciting for me, representing our coalition and our interests of trying to really increase access to care where and when people need it, is it is not a partisan issue, and this is such a polarized time. And I think that the great panels that you brought together is emblematic of that, and that means that we can actually have hopefully some consensus and actually start making things permanent. And I would say that's really my big magic wand, is permanency and clear-eyed regulations, both for things that are obvious that we can do effectively now through the advent of technology. Easier said than done, but we actually know what we can do now in a clinically appropriate way, removing barriers as best we can at the federal level and state level and making those items permanent. And then also having a flexible, workable, future-looking set of policies in place that aren't inhibiting where technology can and will be going. And of course, you're going to have to update things. Of course, you're going to have to make tweaks. But if we could have some sense of policy coherence and predictability and permanency, I think that would go a long way towards doing what we're trying to do now, which is empowering people to live healthier, longer, happier lives within their own power, within their own capabilities, and removing so much of that burden on other providers as best we can. Because while I sounded very optimistic there, it's really hard to do good public policy in a predictable way. Our system is set up that way. The federal government's more dysfunctional than ever up on Capitol Hill, and I say that loving the folks up on Capitol Hill, having worked on Capitol Hill. It's really hard for them to get their minds wrapped around their day jobs, let alone looking into the future, let alone making permanent the self-evident things like the Medicare telehealth flexibilities and acute hospital care at home, things that we've led on and innovated on, and that President Trump on a bipartisan basis put in place in the first term, and it's been kept in place ever since. And also we have this federal system with states going 50 different directions. And so that's something that we've got to be mindful of and tackle and do it in a thoughtful way, and hopefully come up with ideas that are so overwhelmingly the right thing to do that we remove these barriers. ATA, we represent the whole width and breadth of healthcare. That's hospital systems, academic medical centers, folks like Johns Hopkins, but also solution providers, virtual-only providers. We have got medical device manufacturers, connected devices. We acquired last year the Digital Therapeutics Alliance, and so we're trying to really push forward on the whole host of issues broader than just telehealth as limited as defined in a limited way. And I want that predictability for, of course, telehealth and virtual care, which are the things that we are doing now very effectively, and want that predictability across all 50 states. And to me, the biggest benefit, if you just boil down telehealth, virtual care to its core component, is access. The American healthcare system, as was just noted, is we're not getting our money's worth. We're not getting the value of the dollar for every dollar we invest in healthcare, despite the huge amount that we do. We still leave too many people behind, still have too many healthcare deserts. We have an ever-increasing number of rural hospitals that are closing. But even if you look at suburban and urban America, good luck trying to get a provider's appointment quickly, even in an emergency, unless you go into an emergency room. So we got to improve access. I think what's really exciting and would be so relevant to the conversation that we're having today, and be criminal not to mention it in February 2026, is AI in healthcare. And I think if you pair AI with telehealth and virtual care technologies, connected devices, you can make the most of the reams of data that we can produce to create those individualized, bespoke healthcare plans. And I think it also will be really important to improve precision healthcare. Johns Hopkins said in 2016, I don't think it's gotten much better, that the American healthcare system costs upwards of 250,000 lives a year, year in, year out, because of human error. Think about also the great deal of costs that go into human error. And if we can wring out human error through the use of AI and try to hone in on this area of precision healthcare, I think that's going to start finally bending that curve of lifespan up and allow people to be empowered to make the right choices. It all comes down, though, to predictability, and that's our biggest challenge. We've got to be real about that.
Sure. Thanks, Kyle. Ben, please.
Yeah, thanks, Mark. I appreciate the invitation and being here and learning from everybody. I think you talk about, so my name is Ben Wiegand. I'm from the flagship Pioneering. We're a venture creation firm. So we do some investments. We really try to create new ventures. Our tagline, if you would see it, is "What if?" So this idea of a magic wand, or we're trying to envision the future. We believe fundamentally. I want to ask you to raise your hand, but if I would, how many of you would want to get sick? Most of you would keep your hand down. Nobody wants that. Our system is set up, as was mentioned already this morning, to deal with people when they are sick, versus trying to keep people healthy. And it's for good reasons, right? If you go back, over a century ago, people would present with lung cancer when they started coughing up blood, right? We didn't have x-rays back then. We didn't have CT scans. So they did the best that they could, and they actually did a reasonably good job. Although, as we've heard in the last presentations, the difference, what we've got to is a world where people are living longer, unhealthier lives versus longer, healthier lives. I think as we want to take the difference between lifespan and health span and make it as small as possible, if I could say it that way. I haven't seen the latest data. I think the 2024 data said the US was the best at living longer, unhealthier lives. So our difference between lifespan and health span was the largest of any other 186 member countries of the WHO. So we need to do something about that. Our thought is, what could we do if we could give everyone a decade of healthier living? So that's our what if. And we believe to do that, if we could do a better job predicting, as was just mentioned, detecting, so to know where you would want to put your resources at, and then preempting disease, we could make a difference. Because frankly, the majority of that difference in lifespan and health span is due to 4 major chronic diseases: metabolic health, cancer, immune health, and oncology. So we believe now we have the ability, and if you look at it, there are 3 seminal papers that just have come out in the last 6 months, where people have been able to predict, again, not saying it's perfect, but predict with 20-year vision in the future of where your health is headed. And if you think of health as a journey, what we want to do is to help people on their journey maximize, or at least give them the choices of where to go. I grew up in the 70s, where when we went on a family trip, we went to the AAA and they gave us a map and they said, here's the direction you want to take. Now, if you don't want to take that way, it's fine. Here's some other roads, but it may cost a little bit more. It may take a little bit more time. We believe today that with our health journey, we can help people understand where to go. And look, if you want to do a little bit different and make different choices, well, here's the cost that it would be to your health, and you can make those choices yourself. Maybe just a last thought, and then we can talk more about how to dimensionalize it. But a rationale that we had, and if you'd go back maybe 30 years ago and someone would ask us the question about, the future of travel, you would never have thought where travel is today is where we were at 30 years ago. So we would say it this way. 30 years ago, we would drive the cars, and because we didn't know enough about our health drove us. We believe there's a future that's today, and actually getting better and better every day, where we actually can be driven by cars, so we're not driving our cars ourselves, right? That was a concept 30 years ago, that's almost Star Trekian in some way, shape, or form. But now it's real if you go in a number of different places. And we should be able to have dashboards where we know more about the health of our bodies than the health of our cars. Because our cars, we change every 4 years, and at least today, the bodies we have are the ones we're privileged to use for as long as we have time here upon Earth. So that's the vision we're headed to, so predicting, detecting, and preempting health. And we believe we need a system that supports not just sick care, but supports health care. And we can talk more about how we believe generative AI and technology can enable that.
Thanks so much, Ben. My favorite person, Mark Peterson.
I was going to say, you want to throw in a little jab more about me
No,
being an
never.
actuary, or
No,
now that the party's starting? Or?
Yeah, I actually have one more. So he's run every day, I believe, for the past 5 years.
I've ran every day outside for about 6 years. Now, for those keeping score at home, I'm from Minnesota. And yes, it gets quite cold. And yes, I still go outside.
Yeah, he also eats ice cream every day, so.
Thank you.
Actuarial hedge, I guess. Please. Sorry.
Some people run, for whatever. I do it to, allow myself to eat ice cream for breakfast, yes. Speaking of where healthcare needs to go, obviously.
I guess we're going to have the fight. So.
Yeah, so this is where the conflict is going to be on this panel, is you and I? Is that what?
I would actually win the battle. It's on Polymarket.
But like Mark was saying, I am an actuary. Full disclosure, I am also married to an actuary. So yes, our kids, there is no greater pressure. You could think speaking in front of 500 or 600 people is really going to be a lot of pressure, but no, wait until they have to bring a math test home. I currently am working at an organization called NextBen. We are betting big on the defined contribution space with regard to healthcare. And why I think that is, all you have to do really over the last 5 years is look at what's happened in the world. You can't tell me that you were not seeing unprecedented uncertainty everywhere, whether it's COVID, politics, trend, mental health crisis, AI. You have literally uncertainty banging down the door every day, everywhere. So about 6 months ago, I kind of came up with my own kind of personal thesis that assets that are really leveraging and kind of leaning into providing certainty in the world are massively undervalued. And I found this organization that really wants to kind of be at the central hub of kind of empowering healthcare and putting really more choice back in the individual's hands. And after listening to the first panel, I feel like I'm really betting on the right thing, because what you heard from, Steve in the last one with the whole reaching down, pulling somebody up, that kind of moment, it really feels like we're kind of getting to that part where individuals are going to start to take ownership of their own healthcare. And our organization is kind of at the central hub because the way I kind of see it is employers are just tired of the current system. You know, as much as they, want to support their employees and provide a great set of benefits, whether it's rate increases or what, or maybe too small or too big and fully insured, you don't want to pay all those extra fees and whatever, they just want to provide a benefit at a reasonable price. And so the space that we're participating in really is, all right, employer, I'm going to give my employees $500 a month. You go out to the ACA exchanges or off exchange and you go buy whatever plan meets your needs. So for Atala, like if he can go and find a plan that actually offers pink socks, he clearly is going to buy into that, So meeting people where they are and trying to empower individuals really is where I think the market is going to go. I think giving people transparency and some level of control, which is what you guys do better than everybody, like providing wearables that, provide real-time feedback that allow people to kind of really understand how their body is evolving and changing and reacting to different stimuli from external forces, like, that's great. Now we just need to figure out how we can actually match that price with that risk. And so that's where I kind of look to you guys to help me try to understand how do I define what the risk of, Mr. Pink Socks over here is wearing. How do I try to really understand what Mark Atala should cost next year based on the life choices and the data that you guys are creating and moving through your system?
Grateful for your participation in this panel. So I think with that, the question really is adoption for us. So we put out a AIRFI. I think comments are due the 23rd, I believe. Really understanding the one HHS policy on the framework we're taking, which is first question is regulation. So what regulation needs to change, needs to be evolved to really enable AI. Next really is reimbursement. So in the commercial space, reimbursement is set either through plan design or through different regulations that govern plan design, but on Medicare and Medicaid space, in part states and part federal government. And then really R&D is the last bucket of that, which is when we say R&D, what we're really focused on is tech dissemination. So continuous glucose monitors, for example, incredible technology. Took a long time to be adopted, even in the type 1 diabetic space, where those patients need to check their blood sugar pretty frequently. So I think in that space, if we put on the technology adoption hat, does it just happen? Like, what do we need to do to actually enable this? And I think that the follow-up question to that will be, like, what technologies should we think about in this broad stool of providers, payers, and the technologists that are here? So, Sarah, I'll hand to you first.
Well, sure, thank you. And just back to your health span point, we gerontologists like to say that the ideal thing would be to live to be 95 and then shot by a jealous lover, because then your health span and your life would be exactly one thing. So I think I'm not going to be able to answer all of the regulation parts, but I think as we've talked, so with this neighborhood nursing idea, imagine if everyone had access to a nurse and a community health worker wherever they were, and that neighborhoods that had higher need, more food insecurity, had a higher ratio, and neighborhoods that were wealthy had fewer, but that you were working from a population health basis. As we've talked to payers and providers and federal and commercial insurers, what they've said, of course, is they would want to be able to have this savings attributed to them for the part of the nurse that they're paying for, and that people would be happy to chip in a fractionated way if they could get paid back in that fractionated way. And I'm in Maryland, and Maryland has a history of great innovation in terms of payment, but it tends to work through the hospitals because that's the history of it. And the history in Maryland has been that we don't have charity hospitals. All the hospitals work together, and they work through a commission to have paid rates. But what ends up happening is the hospitals feel like it's their money, rather than it's the insurers and the taxpayers, money that we're all paying into. And so if you really think about a world where we're thinking about health, not recovery from injury, which is also important, but if you think of the four things that have been raised, oncology and the other ones, that all starts with where we are every day and what we're experiencing every day, and our genes, of course. But so to be able to give, I think, certainty, as you said, and also to be able to not have the hospitals in control of this tech adoption, but have it to be much more daily life, and also be able to attribute at its smaller area than zip codes, because we're going to need much more of being able to attribute health and expenses and the wearables in a much more granular, almost individual or block by block way. And I think whether people want to pursue neighborhood nursing or not, that will be useful for everyone, no matter what system we're in.
So again, I'll go back to this. The administration has really been very bullish on health and tech, and they deserve applause. And when I talk about the Trump administration, what they did the first time around, and I said this during the Biden years and continue to say it now in rooms of different partisan stripes, everybody seems to acknowledge that. Again, there is this consensus. I would go back to what I said the first time around. If we don't have, however, predictability and understanding of what the rules of the road are, for instance, for AI in general, which is not my thing, and there's other smart folks on that, but for AI in healthcare, if we don't know what the rules of the road are, and to their great credit, Trump gets this, and HHS gets this, and having a federal framework that's workable, flexible, future-looking, it's going to really be drips and drabs in terms of the expansion of AI in healthcare. And you're going to do what we see in state governments now. Virtually every state government's in session right now. They're going to get, absent a federal framework, very eager to start legislating. And the big companies, the multi-billion and trillion-dollar companies, they're going to have the money, and I represent some of them, and I love a lot of the work they're doing, and it's really important. They're going to be able to navigate the state-by-state patchwork of unpredictability, and they're going to be able to come up with models that work on the state-by-state basis. But the smaller, more innovative companies, the startups, the medium-sized organizations, the nonprofits, the healthcare systems that are dealing with 100 other things, they're not going to adopt it. So I think what we need to do is do our best to meet what President Trump is trying to do with this executive order, but do it in a way that gives reassurance. HIPAA has really bred a great deal of confidence in the American people. It's been updated a few times over the last 30 years by Congress in a pretty thoughtful way. There's a level of predictability such that HIPAA is exempted from most state health data privacy laws. We want to see FDA-cleared devices exempted from state laws. And so there needs to be more and more momentum towards getting FDA-cleared devices out there. But we've also just got to start really talking to our state governments and working with smart folks at HHS, working with smart folks in the room here, and this might be a little pie in the sky, but try to come up with some kind of comprehensive federal framework, at the very least for AI in healthcare, that would allow for predictability. And then once we handle that, then we can really get to the sticky questions of coverage and reimbursement and what that coverage and reimbursement looks like. But until you have that basic level of regulatory certainty, it's going to come in drips and drabs, and it could lead to state patchwork quilt of laws that won't allow for the full potential of this technology.
Ben, please.
So want to build on one of the comments that I think the Assistant Secretary talked about this morning is we believe in a try-it model. And so I think we are, in fact, if you look at health, a lot of things that happen in health are behaviorally driven. And there's good research now that shows a lot of these choices we make are socially driven. And that we're affected by our community, whether it's our local community or our digital community or whatever community that we're in. And so it helps us if we start thinking about, if you have good stories, and those stories are proliferated, that makes you more successful. So I want to share maybe 3 quick thoughts. One is, I knew I was coming to this meeting today, and so last week I picked up an app. I'm not represent the app. I have no relationship with the app in any way, shape, or form, the company, but it's called Verily Me. And I downloaded all my health records over the last 20 years. Now, I say that cautiously because, frankly, I couldn't tell you all my health records over the last 20 years. So what I got was over 1,000 of them, and it took a day to do it, and now I have the ability to put, I can put APIs on it to do a bunch of modeling. We do a lot of modeling about predicting. So now I have the data that actually can predict where my health journey is going, which I didn't before. And so I appreciate the work that was done in this collective room and in this country that allows me just, frankly, it's a free app. I hit the button and the data came within a day, and it's really now empowering me to sort of take a more proactive journey on my health. And I think there's a segment of people that will do that. I'm not saying it's a big segment or a small segment, but it's a segment. There's another segment that we are very interested in, and I say this hopefully in the best possible way, where people are very incentivized to take care of their health, and that's women going through pregnancy. They're willing to, thank you. A big round of applause. And why is that? One is because they realize their health is not just affecting their current health. So if you don't know the data, women that present with gestational diabetes have a 5 times higher likelihood of having type 2 diabetes later in their life. In fact, they present 70% of them within the first 5 years post-pregnancy. Same thing with perinatal depression. If you show up with depression, likelihood that you'll have a MDD is 8 times higher later in life. But it's not just for the mother. It's also for the unborn child. And they're putting them at actually additional risk if they're not provided the best health care. And so it's an opportunity to help them who are willing to make changes about the things they eat, the things they do in terms of maybe alcohol, smoking, other types of behaviorals, to give themselves and their child the best possible life. And to be able to provide them the information early on of how to do that, we think is a very positive way to get them on a trajectory, because once those behaviors and habits are put into place and people can see the real-time tangible benefits from them, we believe there's incentives for them to keep that going post. The other thing I would say, and I don't say this in any way but hopefully respectful, as fathers, I have 4 children, and in solidarity with my wife, every time my wife became pregnant, I put on 5 pounds. I gained 20 pounds through the pregnancies. I'm not sure how that happened. But I think it's also saying there's other places where you have a community that could sort of sign into and be a part of that, which we think makes a really big difference. Now, how do these things become adoptable? I think there's 3 things that we think are really, really critical, and Kyle and Sarah both talked to them as well as Mark. There's 3 A's that we look at a lot, and it's not just for wearables, but it's also for AI and for other apps. One is, are they accurate? So the information it's giving you, is it accurate? And so, it's one thing, I used to get frustrated years ago with some of the apps where I'd go for a long walk, and I thought it was 5 miles, and the app would say it wasn't 5 miles, and obviously it was disappointing because you feel like it's not giving the feedback. We don't have that problem today for a lot of wearables that are out there. So the second A is agentic. So does it actually change your behavior in a way that's valuable? Because it's one thing to get a piece of information, but if I don't know what to do with it, that's not going to be helpful. So my mom is 92 years old. Last year, she watched a certain amount of steps she takes a day. She had 6,000 one day. She was going for 8,000. I'm like, Mom, 6,000 is good. You don't need to go. But in her mind, more was better. And so without a context, because today we live in a world that always more is usually better, I was concerned more about, as Sarah mentioned, falls and other types of things at some point where you get tired. And so is it agentic? Does it actually cause a behavior and actually do a positive thing from that? And then the third is accountable. So is that information integrated into a healthcare system that's valuable? There's a lot of things that we do that we should do, and they're a lot of fun. And they could be helpful, but it's not clear that all that is sort of rolls up into a healthcare record at some level. But I think if we can focus on things where they're accurate, agentic, and accountable, and you work with people who are really incentivized either by themselves, or we could use employer or health plan incentives to drive those behaviors, we think we can have this uptake, as you said, Mark, in a much more positive way.
And Ben, I'd love to pull on the thread of maternal health really fast, and then come back to Mark on how technology can actually be deflationary in terms of pricing. So completely hypothetically, if there was a focus on what we can do in terms of maternal health during pregnancy, and then let's say the year after pregnancy, especially with digital solutions, what type of adoption, what type of interest do you think there would be, both on the provider side and then also from the innovator side? Is there enough out there that could really be meaningful to help move the needle on what clearly is a gap in our country?
So I would say we just came back from the UK and from another country that has a single payer system that looks at insurance differently than we do it sometimes. And I think also here in the US, today there's a desire to realize that if you look at gestational diabetes rates, they've increased year over year since 2016. We know the data. The question is, it's hard to do anything about it, and why is that? Traditionally, people aren't diagnosed with gestational diabetes till 23 weeks or later, and by that point, the amount of time to intervene and make a difference in changing the trajectory is really hard to do. If you were able to give people, mothers, pregnant, an app earlier, even preconception, at early time, we think you could identify that in weeks 10 through 15 and actually change the trajectory, right? And so again, look at what we're thinking about is changing the trajectory of health. We don't today think it's going to be a step function that all of a sudden, once this happens, there will be no more gestational diabetes. That's not the case. But if we can change the trajectory of health to a lower, same thing with perinatal depression, it turns out these diseases, if you look at perinatal depression, there's 3 different phenotypes. One that presents preconception, one that presents during the 9 months of conception, and then during pregnancy, and then one that's post-conception. Very different etiologies. You treat them very differently. But again, if you're not tracking that during the time, you don't know how to intervene as effectively, and oftentimes it's trial and error. I say trial and error. It's best guess or best thought process, and we think with Gen AI we can make a more meaningful difference. So there is an appetite because you can get earlier in the disease, and I think all of us would recognize, especially if Sarah mentioned cancer, treating stage 0 cancer or even pre-stage 0 cancer, the outcomes are amazingly better than late-stage cancer, stage 4 cancer. I mean, we're thankful for CAR T therapies. As Mark said, I came from Johnson & Johnson. We're very active in this space. But everyone would say treating it at stage 0, the outcomes are both less costly, affordability is important, but also have much higher cure rates. And so we believe using technology, we can get in earlier and identify and keep people healthy, or if they're on a trajectory, we can help give them suggestions to change that trajectory. Does that make sense?
And if I could just add to that, you mentioned social connection in terms of health behavior. And we know from the Centering Pregnancy model, which is an in-person clinician-led model, that it's a group model. And so all of you know how a lot of people's best friends they made in childbirth class? It's like that, only it's with prenatal care. And there's many ways to consider that you could make that digital, or you could make it, you could strengthen it digitally, or you could have, you could have community members. If there's not enough in your hometown, there could be people who are similar to you in one way or another, who you could be finding digitally. And so I think both in terms of the screening, but also creating that community, and then saying, I had this pain, what do you think? And at any hour of the day or night would be an aspect of that.
And if I could just also say, sorry, just to jump in here, just to say that maternal mortality is one of the great shames of the United States of America. And there's a lot to blame to go around. We have a far higher maternal mortality rate than any one of our other developed peer nations. And the starkness between communities, including, of course, communities of color, is shocking and it's abhorrent. And one of the things that we should always keep in mind is that we're not going to solve all of these challenges solely through the use of technology, including maternal mortality, but how are you going to come up with a solution that's sustainable and it's impactful without the deployment of technology, given the provider shortages, given the great disparities in healthcare outcomes based on geography, socioeconomic status. So you have to integrate technology. But I remember being at HHS first time around. I was at the Office of Global Affairs, and we were trying to take lessons from Rwanda about how to improve maternal mortality here in the United States of America, the largest economy in the world. And so it's something that really is as angering as something could be, given all of the money that we spent, that we have rates at times 3 times higher than our peer nations.
Yeah, so agree. So I hear a yes, there would be interest. Please email us if there are any companies in the audience that would be interested in having that conversation. I think we're certainly interested, hypothetically. So back to Mark. Again, really appreciate you being here. So we really have, so we, in theory, in my head, we're moving from a provider-led system, I love providers, where you show up one time every 6 months for 10 to 15 minutes. That really can't be someone's health. It's critical. It's part of the conversation. It's part of a big part of their health. But it's the questions of what do they do when they're not with their provider. Right. And so if I pair up provider, I pair up essentially technology, and then I pair up the payer, and maybe that's the right mental model, hopefully. How do you think the emergence of wearables, the emergence of really personal health and thinking about a personal health record where I'm wearing, I've got a watch, I've got a phone, that set of data, EHR data, diagnostics, and then medications I take, how does that come together, and can that truly be deflationary? Because I think we keep seeing this building block where new technology needs an additional payment. And how do we at some point say locus of control is back with the person and the patient, and their decision-making is a core part of their primary care and their primary health, frankly, and then how does that actually change this trajectory of where we're headed financially? And maybe talk through ICHRA's, I'm not sure if the audience, it's a somewhat newer product, and the concept of defined contribution, does that pull through the technology even quicker, or your thoughts there?
Yeah, I mean, I think what you're hearing up here is, again, why I'm as big a believer in the defined contribution space as it is. And if it's not even maybe framed that way, it's more from the individual empowerment kind of ownership phase. Because if you were to ask everybody in this room, everybody would say, I want to be healthier. No one would disagree with that. The function that comes down to it, though, is the function of time. Like, do you have time to work out? Do you have time to meal prep? Do you, like, everyone in this room is so busy with their work, their families, their obligations, like everybody's, you look at your calendars and it's slam-packed like everybody's is. So how do you fit owning your own health in a world with today's kind of TikTok 30-second attention span? And that makes it extremely difficult. Now, you all got to kind of see why Ben is one of my favorite people that I've ever worked with. Like, this guy and how he's thinking in terms of incentives and how do we kind of incentivize certain behaviors, I think is absolutely 100% correct. Because at the end of the day, people need to want to take ownership of their health. It's not easy, it's painful, it's slow. I mean, not to kind of talk too much about Ben here, but I mean, Ben went through a health journey, losing a bunch of weight and it wasn't like it just fell off overnight. Like he did the work for an extremely long amount of time and it worked out great. So from a defined contribution perspective, I love the fact that the individuals will have level of control over where their health journey is actually going to be. Now, one of the hardest parts with like the employer market is employee turn, their annual contracts. There's really no incentive from a carrier perspective, from a financial perspective, to make long-term investments because these individuals on these employer plans, they're just not there long-term. So what I'm encouraged about is like the proposed rule that you brought up, Mark, which certain plans might be thinking more, not just annually, maybe it's going to be a multi-year contract. Is there ways to kind of structure a health plan that actually fits with making those types of investments from a carrier or an employer or even from an individual's perspective that really kind of align all the different stars of the constellation that everybody can kind of just stack hands and say, yep, I'm in, let's go this way.
Yeah, and one comment for the audience. I can actually see your questions, so if you have any questions for the audience, if you put them in the Q&A for the app, I'll go through them and ask. When you think about risk horizon for a member, I mean, are you thinking 12 months, 24 months, and then how does that shape this concept of, maybe I need to be thinking about my health rather than focusing on how the payer or the provider can think about it?
Yeah, I mean, one of the biggest headaches of my life right now is how do you match price with risk? And that's not just a health insurance, that's pretty much every aspect, like all the way down to like buying a new car. Like, I'm sorry that's how my head works, but like that's how I function. So if you're telling me that I have to price my risk for health insurance on a 12-month window and only looking at that, that's the vantage point that I'm going to take. And if we can kind of get to a situation where I get to look a little bit longer and I get to be willing to make that, I might be willing to make a bigger investment if I know that they're going to be with my plan in 36 months. I might be willing to, give a little bit more on this and make a little bit bigger investment than I normally would.
And I think that's a critical point here, is to say, a big part of this is how is healthcare financed, right? And so we think about, Medicare at 65 generally, like what's happening in the employer space before pre-65, and then what happens in the Medicaid space. And I think this idea to say longitudinal view of health and longitudinal view of payment and risk really ties into what is the person doing themselves, because frankly, that personal empowerment and that agency is a critical factor here. And so I think with that, this idea of what should we prioritize, you have no one on the stage is a health IT developer. And so I think which is intentional on my part, because I think we want to help bridge this gap where the health IT really matches what providers, what innovators and policy, what investors and what payers are thinking about more cohesively. And so to that extent, I'll pass, anyone in the panel can answer. What do you want the group here to prioritize for what they're thinking about in terms of development? Bring in AI, bring in ease of access. I'll open it up to you guys.
I'll just briefly start. So in terms of health IT and what I think we would want, I'll lay out a few things. One is, I mentioned before, people's daily lives. So not just the wearables, unless the wearables can capture that more. You can do momentary assessment for people's mood, and there's all kinds of things you can do, but not just thinking about kind of the cardiometabolic. I would say also adding in, we can do liquid biopsies now, we can do dried blood spots, can find 5,000 different proteins. It doesn't have to just be the kinds of things of walks. I would say another thing is we haven't really talked about the digital divide, nor much about health equity. So in terms of the digital divide, it's not just that there'll be some early adopters and some late adopters. There's some people who will need someone sitting with them and explaining all the options, for example, or how to get on their internet. And in some places, there's not enough Wi-Fi and broadband. I think also, all of our AI is built on a really biased healthcare system where, like you were mentioning about our maternal mortality, or in most major cities, there are areas where life expectancy is 20 years less than another area of the city. A mile away, right. And so, you hate to say garbage in, garbage out in terms of these important systems that we're all using, but we're going to have to figure out how to modulate for that. And one example is, clinicians have stopped saying, race-based charting, have stopped saying, this delightful African-American man, such and such, 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 because that clues anyone else into reading, oh, this person is an African-American man, and so that shifts for whatever bias they may have. If you just leave out race, that's a big part of moving towards a more equitable system. But we need AI to be able to do that too, where it's not predicting, oh, this person has congestive heart failure and they so-called don't take care of themselves. All that human bias this person was wondering about, the things we say about some people we don't say about other people is in our AI systems. And so we will need to be making sure that we are consciously working to make sure that the algorithms are not reproducing that.
Well, yeah.
A risk-based approach to AI. Not all AI is created equal, and making sure that we're understanding how it's being used, and again, having that forward-looking policy. I think what's wonderful about this moment in time, and it's something that, again, the President, Secretary Kennedy, and your team, Mark, get so much credit for, is trying to think outside of the box with Make America Healthy Again. I think preventative care obviously would save a tremendous amount of money in our healthcare system. One of the things that we're leading on, just to use as an example there, is what we're calling the virtual food care work. And what that means is we're applying the lessons of food as medicine, applying the lessons of social determinants of health, really through a lot of the lens that syncs up so well with what Secretary Kennedy has said for years, which is this idea that let's make sure people are empowered through nutrition-based counseling. That'll save payers money in the long run if you can actually tell people how can you eat nutritious meals every day that will lead to, again, healthier outcomes in terms of prevention. And also, we have a number of different tools the federal government and state governments have in terms of making sure, for instance, our food support programs like SNAP and WIC are covering and encouraging and including home delivery of, because of so many food deserts in this country, medically nutritious meals. I think that alone would save a great deal of money in the long run, really in the medium term for the federal government, for state governments, and it would lead people to live happier, healthier lives in the meantime.
Thanks for both of those. I think, so two thoughts I would share, then maybe an example. So one is, I do think there's some regulatory evolution that needs to happen. And why do I say that? So if for those of you who would know the CANTOS trial, 12,000 person 5-year trial to using a anti-IL-1 beta antibody to reduce heart failure. 12,000 people, 5 years. I'm not sure if I said that. I'll say it one more time. 12,000 people, 5 years. If you think about how much that cost, not everybody can do that trial, number one. If you actually look at the secondary outcomes, which is now has opened up a whole range of new scientific inquiry, in that same trial for people with a certain phenotype, they were able to show a 70% reduction of all cancer. Now, we may be interested in that, hint, hint. But if we have to do a 12,000 person 5-year trial to show that we can prevent cancer, it's going to be really hard. And I'll tell you, today the financial model doesn't support that. If to what Kyle said and Sarah said, we can show that we can take people at risk and reduce their risk by a meaningful way, and then in a phase 4 trial show that that actually is translating to reduction of endpoints of cancer, that would be really helpful for us. And that would incentivize not just us where we're at, but other researchers to go into that space versus saying, we're going to do that work because it's going to be a nice Nature paper, Cell paper, which I'm not trying to say Nature and Cell papers aren't important, but a lot of the researchers are now trying to do more than just get papers, they're really trying to get translational things. So thinking about the regulatory space for prevention is going to be really, really critical for us. Why do I say that? Back to Mark's point, if you look at trajectory of health, if you look at trajectory of cancer over the last 10 years, around 40 to 45 and above, we've changed the trajectory in a much lower rate. We're doing a much better job of early identification, preemption, treatment around that. That's really, really, that's exciting, and we're happy with that. Below 40 or 45, we're actually seeing more virulent cases, and they're actually becoming worse. And it turns out the majority of these are obesity-related cancers. Today, not because of the actuary's fault, we say you have to be this old before you can do some of these screenings. And we're missing a big group of people today that actually have worse cancer, and we don't even have any visibility into them. If we could use the AI tools to do that, that would be a really, really helpful place. Last comment, I do want to make sure that people here realize that the things that we're trying to do, very relevant to keep you healthy, but it's also very relevant for you if you have disease. So I don't know how many of you have heard the term circadian rhythms. I don't know if, I'm curious, raise your hand if you know what time your body wants you to go to sleep at night. There's a way to measure it. You actually, how many of you know what time you should go to bed? Right, versus when you go to bed, so there's difference. So if you look, there was a recent paper in the last month that showed the same immunotherapy given to people at a different time of the day, same immunotherapy, different time of day, 1 year difference in progression-free survival. I would want the doctor to know when my circadian rhythm is and get the extra year. I don't know about you, but I'm voting for the extra year if it's healthier. So the AI that we have and the prediction, the detection tools that are now available for us are not just keeping people healthy, but if you are dealing with symptoms or if you're dealing with disease, they're also very relevant in that space too. Now, I can tell you as a coming from J&J, it would be hard to run multiple time course studies. So again, as you think about how those labels would come out, again, I think FDA regulatory innovation would be really important. Mark.
Yeah, no, thanks.
And some
Ben.
actuarial innovation too. I think that would be a good thing.
That's actually the main set of questions we've gotten are longitudinally this question of incentives. And I think it goes back to plan design, payment, and then how does the money move in the system? And so I think 5 of these questions have really been the why. So we've talked a lot about how. AI will be here. We have wearables. I think tech innovation will continue to have investment and will continue to grow. The question is really the pull through and the why. And so how does that, Mark, I think to your point earlier, how does the world of payment and risk pricing, pull this forward so that we actually do see a longitudinal focus on health?
Yeah, I mean, and just real quick, I want to dovetail off of Ben's comments around the technology, and my ask for you guys is keep working on getting real-time information, but also the why that information is important. Because to Ben's point around the circadian rhythm and all that good stuff, if there's any Garmin people in this audience, I am a big Garmin ecosystem guy. And I love the fact that it tells me the why associated with all the metrics that I get. Because as an actuary, obviously I'm a big data junkie and I like looking at all of my numbers, but being able to understand why I should care about this particular number is obviously really important to me. To your point, I mean, at the end of the day, healthcare spend is literally, for the most part, how many services are needed and what are the costs of those services. Now, from the earlier panel, absolutely with the overcharging, the transparency and all that stuff, that all fits into the price category. And then there's the how many services did you want? So how do we kind of create a system that manages both sides of that equation, I think and how do you incentivize people to actually do certain things?
And you need technology, please.
Yeah.
Just super quick. It's understandable that for employer-based and for Medicaid, we have these kind of one-year churns, and that people fall off of Medicaid. For Medicare, you would think that from 65 on, that's a long enough time that you could plan and have a longer risk horizon. But because we've divided up among companies and you can switch companies every year, we've decreased our ability to do that. And I think those companies do a lot of good. But it would be interesting to play with that time horizon for people in Medicare, where we know the government's going to be paying for it, for as long as someone lives, but the companies might be.
Yeah, so for any med sub plans here, MA plans, Sarah can be found at the Johns Hopkins School of Nursing, and Capable, I believe, is the plug. She's there. I think to that point, and consistent with the Secretary's vision to make America healthy again, and starting in childhood, we can start first in maternal health, and then I think pull that again through to childhood. Does technology play a role there? I know we hear a lot about social media and the question on ensuring that children don't have excessive screen time. What's the view? And Kyle, you may have some thoughts there, given your members.
I don't have a cure-all, and I don't think it's an IT thing necessarily, though it could be encouraged by the use of IT and technology. But exercise, physical activity, and as much as we can encourage that, something as basic as that is really, truly the wonder drug, and that's one of the issues that we've had over the last 3-4 decades. It's leveled off. We might have ways to tackle it with GLP-1, which is going to be mostly for older, more mature, adults. But if we can get folks in youth eating healthy, knowing and having their parents educated about what to give them in terms of healthy food, and then encouraging some degree of half an hour or at least of physical activity a day, I think that'll be go a long way.
Thoughts?
No, I think there's a really lot of good data that says the first 3 years of life are the most impressionable to all of your systems, whether it's immune system, endocrine system, inflammation system, et cetera. And so I think helping people understand how that goes, again, without making people nervous. I mean, that's the challenge, is you don't want to give so much information that people will get nervous and not know what to do with it. But we do believe there's ways to present it in a way that can be agentic, positive, provoking, and helping people take better charge of their health.
Okay. I'm grateful you guys all decided to come, including Mark. And hopefully this was informative. And Tom may be the hand that comes down and grabs me, and so I can't do this next year, but we'll see how that goes. I'm grateful again. Please, thank you so much for being here. Thank you. Oh, I think it.